Hi, everyone. I'm Sandy Suffy, and I'm a professor of health humanities and history and disability studies at UIC. And on behalf of IRRPP and the Department of Medical Education in the College of Medicine, I want to welcome everyone to the 2022 Embodied Inequalities and Begando Keynote Lectures. We are so excited to hear Dr. Davis's work on the urgent problem of racism and reproduction. For the past several years, the Department of Medical Education has collaborated with IRRPP to merge our two keynote lecture events to explore issues that are pertinent to the intersection of health, illness, and disability in society. In particular, we have co-sponsored events dealing with the intersection of race and medicine. Our partnership brings together East and West campuses with the purpose of widening perspectives and knowledge across the university. For its part, the Department of Medical Education's Joseph S. Begando Lecture brings to campus scholars who work in the field of health humanities and social sciences. This lectureship is part of our department's health humanities education, scholarship, and programming efforts in the medical school. So there are a few logistical things we want to let you know about for today's event. First, we are recording the event. It will be shown by our public access partner, CAN TV, on their YouTube page, and we will post it to our website and send a link to everyone who has registered. For access, we are using Zoom's version of live transcription to caption this event. You can access the transcription with the CC button at the bottom of the Zoom screen. This transcription is not perfect, and we want to apologize in advance for any mistakes it makes, but it is the best we have right now. Please note that we will drop links in the chat throughout today's webinar and invite everyone to ask questions for our presenters through the Q&A function in Zoom. Now, I would like to introduce UIC's Provost Javier Reyes. We are thrilled that he is able to attend today's event. Javier Reyes, my Spanish is terrible, even though my husband is from South America. Anyway, sorry. Javier Reyes is the university's Chief Academic Officer. In this role, he advises on matters of academic policy, strategic direction, enrollment management, and academic resource planning. Prior to joining UIC in the summer of 2021, Provost Reyes was the Vice President of Startup West Virginia and was the Milan Puskar Dean of the John Chambers College of Business and Economics at West Virginia University. Dr. Reyes is deeply committed to the university's vision of enhancing justice, equity, diversity, and inclusion, which he affectionately refers to as the Jedi Way. With this deep commitment, Dr. Reyes champions student and faculty success and seeks to amplify UIC's visibility and reputation locally and beyond. He tries to elevate the impact we have in and with the communities with which we engage, and strives to inspire and harness the innovative and entrepreneurial spirit on campus. So, Dr. Reyes, we welcome you to give a few opening remarks, and I apologize again for my butchering your name.
Sandy, no need to apologize, and please don't ever do that. It's okay. Rolling my R's sometimes it gets me in trouble as well. So, but thank you, Sandy, and good afternoon, everyone. Thank you for inviting me to join you today for such a remarkable event. It is a pleasure to be with you. I know it's virtually, but sometimes I think that these virtual events have given us a window of opportunity to take advantage of being able to connect with people that are in different parts of the world, the country, sometimes the city. So I see that the attendance is really high, and I'm sure that many of you are taking advantage of that virtual possibilities that we have now. But on behalf of all UIC, please allow me to reiterate our gratitude to all our students, our faculty and staff, as well as members of the public for joining us today for this very special collaborative lecture and discussion. And let me emphasize that, the special collaborative lecture and discussion, which I think it's a very, very important aspect of today's conversation. A very special thank you also to Dr. Davis and Carrie Stewart for sharing your time with us this afternoon. We are thrilled to be in your presence and to learn from you, from your experiences, your experts' perspectives, and how these two intersect. But before we start, I wanted to just talk a little bit about the significance of what we will be hearing about today. As many of you know, UIC is home to 16 distinct colleges, each dedicated to the advancement of knowledge in service of the communities that we're surrounded by and to which we belong. But in today's rapidly changing world, we're faced with complex and interconnected problems that affect all of us, and to be honest, which they can no longer be solved by experts in one field alone. In order to solve the challenge that we face in our public health and our environment, to our own existence, our students, faculty, and staff at UIC are called upon to forge new collaborative and creative solutions to address new and old problems. In other words, we want to create a more positive, just, and sustainable future, and we cannot do this alone. This afternoon is an example of the many ways that researchers at UIC and beyond come together across disciplines to transform our world for the better. And in recent years, many have heard of the interdisciplinary research that has yielded incredible advances in remote surgical techniques, innovative online teaching environments, developing new and sustainable building materials, the intersection of policy, human rights, and public health, and many more. Today, however, you will hear from two experts in separate yet related fields about the central role that medical racism plays in the disturbing ongoing trends of premature births, as well as maternal mortality in the Black community, and what that means for future practitioners and researchers committed to changing these grim realities. You know well that we live in one of the country's most segregated cities, and in a country struggling to reckon with a legacy of racism and white supremacy. Considering this, considering this work like that of our speakers today, which takes aim to the root of one of many aspects of historic and ongoing systemic racism, is of the utmost importance to each of us. As members of an institution dedicated to creating knowledge that transforms the world, in addition to training the next generation of medical professionals, we have an obligation to celebrate, internalize, and carry the lessons we will learn today into our classrooms, our clinics, our labs, and our communities. I will now turn it over to Amanda Lewis, Director of the Institute for Research and Race and Public Policy, to introduce our speaker and discussant. Amanda, thank you for having me today.
Thank you so much, Provost Reyes, for being here today. We are thrilled to have you on campus and thrilled you're able to join us today. Welcome, everybody. My name is Amanda Lewis, and I'm the Director of the Institute for Research on Race and Public Policy. For anybody who's having trouble finding it, the closed captioning is available by clicking on the live transcript button next to the Q&A at the bottom of your Zoom window. And please let us know if you have any other questions or logistical issues in the Q&A box. So the Institute for Research on Race and Public Policy works to increase society's understanding of the root causes of racial and ethnic inequality, and to provide the public, organizers, practitioners, and policymakers with research-based policy solutions. On behalf of the entire IRRPP staff, we are always glad to collaborate with the College of Medicine and Medical Humanities program in this joint event, which is part of our Embodied Inequalities lecture series. This series is intended as part of our broader efforts to build on the important work about racial disparities in health, to explore why race and racism matter so much for health and for health outcomes. And we are thrilled today in that light to welcome Dr. Dána-Ain Davis to be with us today. Dr. Davis is a professor of urban studies and director of the Center for the Study of Women and Society at the Graduate Center at Queens College, City of New York. She's focused her attention in the last decade on reproduction, race, and technologies that assist in reproduction. She's written several articles addressing these issues, and her book, which we'll be hearing about today, Reproductive Injustice, Racism, Pregnancy, and Premature Birth, has won several awards. Dr. Davis is a doula, and she has been engaged in social justice, particularly reproductive justice and racial justice work for over 30 years. She is a brilliant scholar activist and a warm and lovely human being, and please join me in welcoming her here today to share with us her important work. There she is. Welcome.
Thank you so very much for that wonderful, wonderful introduction. I am so delighted to be here today. I appreciate the invitation from the Institute for Research on Race and Public Policy and the Department of Medical Education. I'm honored to be giving this lecture today. I also want to just take a moment to thank several people. Shakura Evans, who facilitated my ability in giving this talk and handled some behind the scenes issues, not issues, but things. I want to thank Yvonne Arenas and Mary Kelly and Dina Lewis, who are dealing with, I think, technical aspects of this talk. Thank you, Provost Reyes, Sandy, Safian, and I am really very excited to be in conversation with Carrie Stewart. And finally, I want to thank all of you for joining today. Hi, Carrie. And I'm very honored that you took the time to be here. I'm going to just jump right in. I'm going to share my screen, which always comes with a little bit of anxiety, but okay, I think you all can see this. Yes? Somebody give me a hand, thumbs up. Yes, I think you can. Thank you. So I apologize for the sort of low resolution of this, but when I blew these two photos up, they didn't look so great. I'm going to start by just saying that media attention centers on Black women's pregnancy-related deaths. That's mostly what we hear about. When we look at the popular press and read stories about Black women and adverse birth outcomes, we hear about professionals like Shalon Irving, who, if you look at the arrow, is right there, who is an epidemiologist who worked for the Centers for Disease Control. Or we hear about Kira Johnson, who's the daughter-in-law of the well-known California-based judge Glenda Hatchett. And they were among very well-resourced Black women who died after childbirth. Both Irving and Johnson are evidence of statistical data. They are evidence of a racial calculus that confirms Black death. They are the flesh and the bones and blood making made known to us that Black mothers die during or within 1 year of giving birth at a rate of 3 to 4 times that of white mothers. Yet, maternal death is not the only crisis that Black women face. Other data reveal that Black women are 47% more likely to give birth prematurely. And that is the leading cause of neonatal and infant mortality. Since 2016, every year in November, which is National Prematurity Awareness Month, I wait for the March of Dimes to release its preterm birth report card. And from this birth rate report card, we learn that maternal and infant health burdens hover over Black women's lives. And I just want to make a note here that I'm referring to Black women because that is how the people that I conducted my research with identify. But at various times throughout, I'm going to use the term birthing people to really pay attention to how Black people who do not identify as women experience racism as well. So this is the map that I wait for every November. And what this map shows in a nutshell is the premature birth rates across the country from 2021. So in 2022, in 2020. And then in 2022, in November, we'll see the data from 2021. But a very desirable premature birth rate, if you want to call it that, is 8% or less. But if you look at this March of Dimes map, only one state, which is in purple, the state of Vermont, achieved that rate. No other state received a grade of A or A minus. All of the green states have rates of premature birth between 8.2 and 9.2%. And there are a total of 10 of those states that received a grade of B minus or better. 38 states received a C plus or worse. So this is the light blue, the yellow, and the red. And that includes the state of Illinois. And so for context, all of those states that are in red had a preterm birth rate that was equal to or greater than 11.5%. The overall rate, premature birth rate for Black women is 14%. So the 2021 report will tell you that basically in the United States, the preterm birth rate among Black women is 51% higher than among all other women. Scholars of public health posit that premature birth is associated with a range of factors that are divided into the three categories that you see here: social, personal, and economic characteristics, pregnancy and medical conditions, and then behavioral circumstances such as smoking, drinking, or stress. Obviously, as you can see, under the social, personal, and economic characteristics are three factors, one of which is Black race and low income. Most scholars deploy statistics to illustrate the adverse outcome of premature birth, but I think in doing so, what they do is distance the outcomes from racial science, from racial ideology, from medical practice, from US enslavement, and from anti-Black racism. And it is racism that many of us think are the factors that are associated with adverse birth outcomes and not race. So I take up a different approach in reproductive injustice, and that is to learn from Black women's birth stories about what racism feels like to Black women who have narrated their pregnancies, their labors, their births, and their postpartum experiences. And then I link those stories to material that I find in the archive. Anthropologists have long noted that race is not a useful concept, and its use has been debated by biological anthropologists for many years, because many will say there is no biological basis for race. But rather, as many have proven, it is more useful to consider race as a social construction. But one of the challenges in anthropology is anthropology, I think, up until recently, has lost its voice in exploring racism. Scholars like Leith Mullings and Faye Harrison have noted that we have lost the voice. In 2020, at a roundtable with a group of scholars interested in exploring racism in biology, Leith Mullings noted, "It is not sufficient to name racism." She asked, "How do we understand it? And what are its social consequences?" In the book, Reproductive Injustice, Racism, Pregnancy, and Premature Birth, I take aim at understanding not just adverse birth outcomes as a crisis choreographed on raced bodies. I am invested in exploring what racism means to the people who experience it, how racism becomes enacted as a particular set of practices during medical encounters, and how perpetrators actually normalize racism and substantiate its pervasiveness. So I reconsider social science and public health's proclivity to dramatize reproductive health issues using poor and low-income women as mascots of adverse birth outcomes, and they do so without challenging how economics are naturalized explanations. Alternatively, I draw on Black women's stories who have various degrees of social capital to show that class is not the only way that we can account for outcomes, but also to show that adverse outcomes are not the only thing that weighs down birthing people. And I say that because in some instances, people actually have very positive birth outcomes, but their interactions with medical professionals are quite negative. So I analyze these stories and modes of saving premature infants in relation to the past. That is, I look at archives, both recent and distant. It's my way of pretending to be an historian. And I do that to get at what Saidiya Hartman has termed the afterlife of slavery. And I do so to demonstrate how the afterlife of slavery emerges contemporarily in Black women and birthing people's medical encounters. So said differently, I use the concept of the afterlife of slavery to examine the journey of racist ideas from the past to the present through the lens of prematurity. So what is the afterlife of slavery? This is Saidiya Hartman's quote. Slavery had established a measure of man and a ranking of life and worth that has yet to be undone. If slavery persists as an issue in the political life of Black America, it is not because of an antiquarian obsession with bygone days or the burden of a too long memory, because Black lives are still imperiled and devalued by a racial calculus and a political arithmetic that were entrenched centuries ago. This is the afterlife of slavery: skewed life chances, limited access to health and education, premature death, incarceration, and impoverishment. So I use the afterlife of slavery both methodologically and analytically to make these connections between contemporary experiences described to me by Black women and prior histories of how racial science and the medical establishment viewed Black bodies that has had consequences for birthing prematurity, postpartum, infant mortality, and medical treatments. Drawing from various archives, again, I use the past to give meaning to the ethnographic present. And so there are various ways in which the book deploys the afterlife concept. So what I'm going to do is walk you through some of the chapters of the book. So I look at prematurity in the afterlife of racial science. There's a chapter that looks at pregnancy and prematurity in the afterlife of slavery. I examine saving Black infants in the afterlife of slavery. I look at an afterlife of racial disparity and the afterlife of slavery and radical birth work. Prematurity in the afterlife of racial science is the subject of the first chapter, in which I try to illustrate how racial science has an afterlife in the research of premature birth. In this chapter, I argue that there has been this migration of racial science from anatomists, naturalists, physicians, et cetera, from 16th, 17th, and 18th century, centering on differentiating Africans, people of African descent, from whites. In other words, there was a search, as you all well know, for traits that differentiated people. So these logics of racial differentiation actually found their way into thinking about prematurity. The defining characteristic of prematurity was finalized in 1935, and there were two events that precipitated the definitional standardization of prematurity. The first was the implementation of birth registries in the US, and the second were the findings of Arvo Yilpo, who is right there. He was a Finnish pediatrician who had conducted anatomical and pathological analyses between 1909 and 1918 on about 2,000 infants. But he also conducted autopsies on 114 and determined that it was a weight of 2,500 grams that defined preterm. And it's been acknowledged that he never justified the weight limit, but it did become a standard and it influenced public health practice. By 1935, the American Academy of Pediatrics had resolved that all live-born infants weighing 2,500 grams at birth should be treated as premature regardless of gestation. And it was later when gestation became added to the definition. But just as proponents of racial hierarchy used science to distinguish Negroes from whites, so too was scientific racism deployed in the interest of manipulating racial differences in fetuses and prematurely born neonates. In 1948, this book, or pamphlet rather, was published by the Children's Bureau, and it's called Premature Infants, a Manual for Physicians, written by Ethel C. Dunham. Premature Infants describes many things, including prematurity's definitional and etiological parameters. But the pamphlet also possesses a trove of sources showing how doctors used premature birth to establish a fact, or tried to establish a fact of racial difference. Again, looking for traits showing differences between Negro and white premature infants. So some studies looked at weight and race, for example, as factors that define prematurity. One study analyzed the role of the occipitofrontal circumference, which is the largest horizontal circumference of the head, in an effort to distinguish between Negro and white premature infants. Another study examined X-rays of 3 areas where tissue was formed in infants: the thigh shaft, the bone on the outer side of the foot, and the wrist. And this doctor, whose name was Amos Christie, was trying to determine whether bone tissue formation, or lack thereof, could be estimated by weight and then serve as a predictor of maturity or prematurity based on race or sex. So all of this is to say that there are these contemporary ideas about pregnancy and causes of prematurity that can be traced back to these earlier efforts that try to concretize racial difference. And one case in point comes from the work of Teresa Overfield, who was a nurse anthropologist. She was well regarded, but also critiqued, for a text in which she noted that Blacks have a shorter gestational length and thus are premature. And she suggests that the reason for this is adaptive. The adaptation is due to Black women's smaller pelvises. In other words, she's doing this link, linking race and prematurity or shorter gestational lengths because Black women have smaller pelvis than white women. And there was, starting around 1820, I think, there was a whole study where people were really interested in differences in pelvis size and pelvis shape. So this is probably going to be the longest part of my talk because this is where the ethnographic data starts to begin to take a different kind of shape. Pregnancy and prematurity in the afterlife of slavery. I'm interested here in how the afterlife of slavery shows up ideologically and in practice through the treatment of pregnant people, which results in what I would call as a sort of diagnostic dystopia. In this particular chapter, I offer a close reading of a Black woman's birth story, and I use archival sources as the context against which to assess and translate her contemporary medical encounters. This is a piece in which, or this is a chapter in which I focus on a woman named Yvette Santana, whose narrative is riddled and complicated with and by oversight. At 40 years of age, Yvette, who was an administrator at a university, and her husband Carlos decided to start a family. She quickly found out that she had fibroids, which was complicating conception. She had 2 myomectomies, which facilitated then a successful use of in vitro fertilization. And she learned that she was having twins when she was around 3 months pregnant. Everything about Yvette's case actually should have signaled close monitoring. But her OBGYN, who in fact specialized in high-risk pregnancies, viewed her pregnancy with very little concern. And Yvette attributes his indifference to a comment that she says he made. And Yvette said that he said she did not have the markers of being Black. She did not have high blood pressure, nor did she have diabetes, which are also indicators of high-risk pregnancy. And in fact, according to Yvette, her doctor accused her of hypochondria and asked if she were trying to make herself high risk. Due to what she perceived as the physician's lack of concern, Yvette searched for and found another doctor in Washington, D.C. She and her husband were in a commuter relationship. And he lived in Washington, she lived in North Carolina. She found another doctor, a Black woman, who actually confirmed Yvette's fears about the potential seriousness of her pregnancy. And then on a trip to Washington, Yvette actually ended up going to a hospital emergency room because she did not feel well. And while she was in the ER, Yvette completed paperwork, but she said that no one really attended to her. She indicated that she felt ill. She indicated that she might be in labor. And instead of addressing that possibility, ER personnel ignored her. She said, and I quote, "I was not manifesting enough symptoms of distress for them to be concerned." Yet Yvette told me that she was in fact continually asked if she were on drugs, and she reported that twice she was tested for methamphetamines. Several hours after arriving at the hospital, her twins were born at 26 weeks. Yvette had given birth prematurely to a girl who was 1 pound 8 ounces and a boy who was 2 pounds 1 ounce. Both children were admitted to the NICU, the neonatal intensive care unit. And during their stay in the NICU, nurses insisted that her twins would survive, although they were small. They kept telling me, "Oh, you know, Black babies make it all the time. There's nothing to worry about. They are so fit." Over 28 days, Yvette spent most of her time in the hospital with her children. And one day she decided to go home, take a shower, and return later in the evening to spend the evening with her babies. Within an hour of leaving the hospital, Yvette received a phone call asking her to return. And when she arrived, she found that her son had died, having succumbed to MRSA, the hospital-based staph infection. The nurses, she said, were shocked at his death, probably given their predictions that Black babies are so strong and fit. Yvette concluded that the nurses' belief in strong Black babies worked against her son. She commented that if they had seen her children as fragile and not strong, then maybe they would have taken better care of her son, and she would have taken home both twins instead of one. At the end of our conversation, Yvette said, "If I had been white with blonde hair, I bet my son would be alive." The incidents marking Yvette's pregnancy, labor, and post-birth exemplify, I think, how racism is marshaled on Black bodies. Histories of medical exploitation and mistreatment hinge on racialist assumptions, such as, "Oh, Black babies are stronger." Yvette's story opens a window into several realms of racism, only one of which I'm going to describe here. In the book, I talk about several others. The one that I'm going to describe here is diagnostic lapses. So diagnostic lapses is an elaboration of Duana Fulwiley's enculturated gene concept. In her ethnography, The Enculturated Gene, Sickle Cell, Health, Politics, and Biological Difference in West Africa, Fulwiley shows us that disease embodiment and management on the part of Senegalese people themselves has minimized the gravity of the severe medical situation by others, in particular French doctors. So a diagnostic lapse, my interpretation or my utilization of that term, is when there is a minimization or an exaggeration of a medical situation. And in this case, it is relative to a racialist presumption. Examples of diagnostic lapses as they pertain to Black women's health are consistent with histories of medical racism. For instance, Marie Jenkins Schwartz provides evidence of how race and class assumptions obscured physicians' abilities to make appropriate diagnoses of a young girl in the antebellum period in 1854. A close reading of the original article, which I searched for and found, which was published in 1854, documents the case of a Negro girl who was age 9 and the property of J. Haywood Jones, Esquire of Mooresville, Alabama. The author of the story, Dr. Gant, reports that in 1852, Dr. Hussey was called to address the medical needs of a 9-year-old girl. It became the undivided opinion of all who saw her that she was pregnant. There's some details about the medical exam that I'm going to leave out for the sake of time, but what was striking was that it never occurred to the doctor nor to the girl's owner that she could be anything but pregnant. And this, I argue, exemplifies the operationalization of a diagnostic lapse. So the girl's race and her status as an enslaved person predisposed those around her to assume a diagnosis that aligned with the perception of her race and her position in the slave economy as a reproducer. And as such, no other diagnostic option was available. I think that the young girl's situation can be calibrated in the contemporary context. The unavailability of another diagnosis was also true for Yvette. So the young girl was only viewed as pregnant because of who she was, Black and enslaved, a person likely representing future profits through her reproductive potential. Yvette was only viewed as healthy and not at risk for an adverse birth outcome due to what she did not have because of who she was, a professional Black woman with no diagnosis of diabetes or high blood pressure. The gravity of her medical condition was overlooked because Yvette did not display illnesses associated with being Black. The physician neglected to attend to the danger that her pregnancy did pose. So in the absence of what her doctor, Yvette's doctor, assumed to be race-specific diseases, hypertension and diabetes, he rendered her health status to be atypical of what was expected of a pregnant Black woman. So the other thing is that diagnostic lapses existed on the part of ER personnel who assumed that she was engaged in drugs and being tested for methamphetamines because she was a Black woman. And she also said because she wasn't screaming and acting a particular kind of way. Her children experienced diagnostic lapses because they were assumed to be healthy because all Black babies are strong. The author of the article, Dr. Gant, conducted an autopsy of the girl and found that she was not pregnant. Rather, she had had a tumor on her liver. It was 15, and I'm quoting, it was 15 inches in circumference and it weighed over 2 pounds. So Yvette gave birth prematurely. She had not used methamphetamines. She was pregnant with twins. She was over the age of 40, which is considered to be old. And she had what some people call a compromised uterus because she'd had myomectomies. Both Yvette and the young girl had health issues that were viewed much too narrowly based on race and status. Saving infants in the afterlife of slavery. This is a chapter that's actually titled Saving the Babies, which examines the interventions, including technological devices, educational campaigns that have been used since the early 20th century to address premature birth. The neonatal intensive care unit, I have argued, is a technological form of assisting with the completion of reproduction. However, this was preceded, the NICU was preceded by other forms of saving. So I deploy the term technologies of saving to capture the power of interventionist saving practices from the early 1900s through the 20th century, while simultaneously harnessing a kind of critical race lens to those technologies. So in this case, I draw from the archives of the Children's Bureau, among other sources, which the Children's Bureau was founded in 1912. And this chapter is really attending to the tension between the state, each state literally in the US, supposed longstanding interest in addressing infant, child, and maternal mortality, and how that interest lacked the strength when viewed through the lens of race. This is a Children's Year postcard that was put out by the Children's Bureau. really prior to the latter part of the 1800s, infant mortality and child mortality was not of huge concern for the United States. It became so, though. The majority of state governments formed child welfare programs. But while infant and child welfare campaigners were ostensibly interested in saving all American babies, that did not translate into saving Black infants. In fact, Black infants were almost entirely excluded from earlier infant welfare campaigns, and this was particularly in the South. And efforts to save infants and children benefited white infants much more, which is evident from this chart, which I am showing you here, fertility and mortality in the United States. It offers us all kinds of data. It's this last column on infant mortality that I'm interested in having you take a look at. But it goes from 1800 to the year 2000. And the infant mortality rates, I'm starting here in 1910, which is simply 2 years prior to the institutionalization of the Children's Welfare Bureau. And we could see that there is a disparity, or difference rather, between white infant mortality and Black infant mortality that is actually held strong, if you will, from 1850 down to 2000 and actually to 2021. As you look down the chart, you can see that Black infant mortality rates are consistently consistently higher than white infant mortality. So the Children's Bureau did a fairly good job of addressing the needs of white infants. Some would argue. The next chapter that, I'm just taking a look at the time. The next chapter is taking a look at the concept of racial disparity in the context of a racist past. Here I go into an archive to try to understand how the term racial disparity shrouds the degree to which racism can be discussed within the March of Dimes. And I choose the March of Dimes because that is the organization where I spoke to a number of people and spent time with them. And I traced the March of Dimes history to shed light on how race has factored into their commitment to improve adverse birth-related issues and infant health. But I became particularly interested in how the organization's past may have animated a concept of racial disparity in premature birth outcomes rather than racism. So in this chapter, I offer a brief history of the March of Dimes, and it shows that Franklin D. Roosevelt, who founded the National Foundation for Infantile Paralysis in 1938 in response to the epidemic of polio that spread person to person, had killed or disabled thousands of Americans, mostly children. The foundation's sole purpose was to find a polio vaccine and provide support for polio patients. I describe how polio, like premature birth, though, was entangled with racial politics, but it was of a different sort. Whereas focusing on race differentials is in fact fundamental to understanding the March of Dimes' effort to end premature birth. That was not the case initially with polio. Initially, there was very little effort spent on addressing the needs of Negroes with polio, due in part to the way racial science had continued to move through social, medical, and political life. Some experts did not believe that the primitive races could contract the same type of diseases that civilized people of Northern European heritage contracted. Dr. George Draper, who actually directed President Roosevelt's therapies, wrote in his text on polio that it was, quote, well-grown, plump, white, native-born children with widely spaced upper front teeth and delicate teenagers who filled hospital beds at doctors' offices during polio outbreaks. Meanwhile, Negroes were supposedly strong and immune from such illnesses. And ultimately, it took the National Foundation for Infantile Paralysis 6 years to begin to pay attention to and address the fact that Negroes were indeed susceptible. So the history, I say, helps to contextualize the issue of how the March of Dimes statistically systematizes racial disparity. I was just interested in how they use what they call a racial disparity index, which is in the report that comes out annually, which shows the actual difference in premature births between different groups of people. The idea of the index was to create an emotional impact of numbers that would make states accountable for their premature birth rates. And the numbers, though, are presumed to be a rational representation of truth to prove that a problem exists. And so essentially, this chapter is I would say it's a gentle critique of the concept of data, and that the use of data as an interventionist strategy and a disciplining regime ends up being all that we want to know about a particular issue. As Toni Morrison said, quote, "You know the formula. There's data, which becomes information, which becomes knowledge. This is what numbers do. They make us think we know who and what we're talking about. So instead of saying, how can we make birthing a great process? We look at how Black birthing people are slotted to risks rather than calling out the ways that the medical complex sustains racism." So I think ultimately what I think is that racial disparity statistics can obscure the issue of racism in the same manner that the National Foundation for Infantile Paralysis obscured and in fact denied Black children from resources during the polio epidemic. And I'm not trying to charge the March of Dimes with anything, but I do note that racial disparity is caused by racism, and that is what I think needs to be said. The Afterlife of Slavery, Anti-Black Racism and Radical Birth Work. In the last chapter, I deploy the archive to illustrate the different ways that Black women's activism and adverse birth outcomes are an extension of and in relation to United States history of anti-Black racism that led to segregated medical treatments. During enslavement and in the afterlife of slavery through the 19th century, the vast majority of births occurred at home under the supervision of traditional midwives who provided reproductive and general health care. However, the power of childbirth was wrested away from women as reproducers and as assistants in the birthing process. Between 1900 and 1940, health officials and medical doctors depicted granny, I put that in quotes because what many of us now say are grand midwives. So they depicted granny midwives and other forms of midwifery as unsafe and illegitimate forms of healthcare by citing egregious mortality rates, as well as racialized claims about Black midwives not being, quote, far removed from the jungles of Africa. They were viewed as primitive and outmoded, and the campaign against midwives worked. Again, we can turn to the archives to find evidence of how physicians utilized professional journals to denigrate midwives. One example comes from a Dr. W.P. Manton on obstetric medicine in an article in the Journal of the American Medical Association. And this is what he said. "There is no doubt that tens of thousands of women are being absolutely murdered by ignorant midwives. Everyone who has ever practiced obstetrics knows how filthy and dirty, how officious and meddlesome these women are. We must tell the people how many women these midwives are killing and how much illness they are causing." Aware of this history, actually, and the way that Black women are treated and have been treated, has led doulas and midwives that I have worked with to re-envision the historical legacy of care that they believe Black women deserve. And I call them radical because they link their caring work to a politic of Black history and Black life. Many of the midwives and the doulas and reproductive advocates that I spend time with develop collaborations with community groups in support of home births, in support of access to midwifery care, in support of access to abortions, and the demedicalization of birthing. They also go beyond birthing. They support food access, housing, economic, and environmental justice. And they have transnational interests in cross-cultural birthing practices and care practices and making transnational connections. They continue the work that Black women have actually always engaged in to ensure our community's health. From the Black Women's Club movement, creating health institutions in Black communities, to historically Black colleges and universities initiating their own medical and dental schools, to the Black Panther Party establishing free clinics to ensure medical services, in which Black women were the backbone of those efforts. Black women have always created strategies to address the ways that racism left Black health unattended to. And following in that same tradition, is where radical Black birth workers exist. So here are just some of the things that I have, I created a compendium of what the kind of work that birth workers do. This is not all in the book, it comes from additional work, but organizing in their communities to ensure that birthing people have both an understanding of and access to a range of quality care options, providing direct care services, testifying before elected officials about birth outcomes, testifying before elected officials about implementing legislation to support various birth practices, organizing for greater insurance reimbursement for home births, midwifery care, and for birthing centers, training medical professionals and policymakers about the important role of support systems, supporting access to abortion, basically engaging in social reproduction. So I'll leave you with a question. What is it that we can actually do to sustain the durability of radical birth workers and that movement? And what is its promise and potential to end medical and what I now call obstetric racism? This book unpacks the meaning that Black women give to their medical encounters. And in sharing Black women's narratives, we learn the affective story of racism, but not just to illuminate the fact of racism, but really to deploy those experiences in shaping the kind of responses and care that birthing people desire in hospitalist and out of hospitalist settings. When most people think of Black women's adverse birth outcomes, they assume that those outcomes are the result of low income or impoverishment, or people's bad behavior, or their unwillingness to follow direct orders from their medical providers. And I'm hoping that the book reveals that people across the class spectrum, across the educational spectrum, have similar kinds of birth outcomes, or that we know that they have similar kinds of birth outcomes and medical encounters. In writing the book, I wanted people to unlearn some things. I wanted people to unlearn the way that society has pigeonholed poor and low-income people as being responsible for their own health and birth outcomes. I wanted readers to unlearn that Black people with various degrees of capital do not experience racism, that there is a malleable rule of exemption. I wanted people to unlearn the fact that we place the medical complex on a pedestal such that we think pregnancy must be medicalized at the expense of having a more expansive view of pregnancy and birthing option and reproductive care. And when I say that, I am not suggesting that there is no place for medicine, but I am saying that we most certainly should have access to more options, including home births and including birthing centers, assuming that there are no complications. In fact, I believe that there should be the same reimbursement rate for a midwife-attended home birth as a hospital birth. I hope that medical providers learn that the clinical expertise that they have must be mediated by the expertise that people have about their own bodies. And even if a person is not right about their self-diagnosis, that does not mean they do not deserve to be heard and talked to with care. And I hope that the book And the work that has emerged out of it allows activists to push for what some of us are calling radical caring on the part of the medical community. That's not just the provision of medical services, but care in how people want to be treated with integrity, as intelligent, with compassion. We cannot make an exact prediction of how the medical system will enact racism, but we do know, drawing from Black women's experiences, we can calculate the likelihood that something will in fact happen. And we should accept that from their point of view, an event was racist. And it's our job to respect that perspective. Why? Because Black women's bodies are indeed archives of racism. Our bodies have been historically experimented upon, deployed for capitalist purposes, used as fodder for political machinations that harm us. From the front of our bodies to the back of our bodies, from the side to the side, the Black body is a restless archive of things done to it, with little to no regard for the consequences that those things leave. The experiments to correct vulvovaginal fistula, the overutilization of C-sections, which occurs at a higher rate for Black women than women of other racial and ethnic groups. The unwillingness to allow for a vaginal birth after a C-section, for forced reproduction, for a history of compulsory sterilization, for sterilizations without consent. Black women are viewed as high promiscuity risks, which has resulted in terminations. Or we have served as a site for testing Depo-Provera without knowledge of the potential risks. These are the ways that racism's lessons are etched on Black bodies. These are the lessons of disregard. These are the lessons that perpetuate the beliefs that Black bodies feel pain differentially, and that Black women who make demands are uncooperative or angry, and that Black women are often viewed outside the bounds of presumed normativity. Transcending normativity comes from being too large, from being too single, from being too poor, too Black, too deviant, too risky, too excessive, too fertile, too queer. We are viewed on a continuum between immunity and susceptibility, which leaves us legible as extraordinary in the most harmful of ways. Being on a continuum of immunity and susceptibility leaves Black women vulnerable to excessive intervention and excessive neglect. We are constantly overdetermined as subjects, and our mediated bodies have become the targets of ideas from the past that have migrated to the way that we are dealt with in the present. And we're deserving of so much more. Thank you.
Oh, Dr. Davis, that was so wonderful. I have so many notes and things, but I want to now welcome Carrie Stewart into the conversation. I also want to remind everybody to please put any questions you have in the Q&A. Carrie Stewart and Dána-Ain Davis will be in conversation for a bit, and then we'll have some time for Q&A. But now let me introduce Carrie. She is the Director of Midwifery Services at the University of Chicago Medical Center. She is a full-scope midwife practicing on the south side of Chicago and the founder of Melanated Midwives, a nonprofit organization that addresses Black maternal health disparities and maternal health deserts through the creation and implementation of evidence-based research, while also providing family planning, prenatal, postpartum, and mental health education sessions within the community. She is the lead co-investigator for a study that is part of a new healthcare program developed in conjunction with University of Illinois Chicago researchers and the Melanated Group Midwifery Care that will compare the usual maternity care to a new care model that combines strategies to improve Black people's experiences and outcomes during pregnancy and postpartum. So I will turn it over to you. Thanks.
Thank you so much, Amanda. Can you hear me, Donna?
Yes, I can.
Amazing, amazing. Thank you so much for your talk. You know, you get goosebumps when you hear all of the words that you describe the Black body, and all true, all stemming from history, and unfortunately experienced still today. But I wanted to thank you for sharing some of the synopsis of the book. I actually encourage everyone to get the book and truly read it from front to in, because it shares lots of knowledge of history and the understanding of what has gotten us to this point and why we do some of the things that we do. But I wanted to go ahead and ask a couple questions. I know we're going to have some here that are going to be shared, but I had a couple that I wanted to ask of you. So in your book, you referenced how in your own prenatal care experience, the doctor was being judgmental and making assumptions with regards to your age and education while being pregnant. And you also stated that how his questioning and bedside manner made you not want to continue your care with him. Can you share with our medical professionals, our healthcare environment, and our birth worker audience, how such questions and an important bedside manner can influence a Black mother's care and experience within the healthcare system?
Sure. Thanks for the question.
Yeah.
So I was pregnant in 1980, which is a really long time ago. And I was going to a clinic because I didn't have health insurance. I was working at an art gallery. And the kinds of questions that I was asked were, as you said, about my education. What actually the doctor was really interested in was whether or not, like, are you married? I don't think I put that in the book. I wasn't. And as I said, I was in college. I was in my last year. And the question about, are you married? What do you do? Was not about the kind of narrative medicine that people deploy now. It was really, it felt very judgmental. Some people have said to me, oh, you know, the kinds of questions that you were asked are similar to the kinds of questions anybody would be asked, whether they're Black or white or Latinx well, actually, they don't say that. They say whether they're Black or white. And I said, I felt then, he may have just been asking questions, but as a Black woman, I thought he was asking those questions because I was Black. And that is not an experience that no white woman I know has ever had. They don't think the questions have to do with race, right? So, and I've seen it as a doula. I've seen doctors make comments, and that's what I write about in the book. Oh, if the father is there, oh, you have a baby daddy? Like what is a medical professional saying that for, right? Like what, you know, how are you feeling is probably more appropriate, you know, but, oh, you have a baby daddy with, you know, and then changing the whole intonation so that, you know, it's just about the way medical professionals carry perceptions that influence bedside manner. Attempts to coerce people and make them feel bad because they think that they think that maybe people of color or Black people are superstitious. I literally helped a family give birth in this past November, and the doctors did not like the fact that she was in the hospital for a day and a half in labor. And so when they switched, when there was a time to switch over with new staff, the OB comes in and she says to the mother, you know, if we don't give you an epidural and we don't speed this up, you know, your uterus is going to fall out. Totally drawing on fear and coercion. And because we had spent time talking about the fact that they would probably do something like that, she said, I want to see the chair of the department. So, did I answer your question?
You did. You know, it's those, and that's just the underlining things of the book and in your talk. You know, interaction and communication are vital pieces to the care that we provide. And I think, you know, something as simple as how you explain diagnosis, is explain a situation, communicate with patients, it'll make a big difference in that outcome. It's been my experience. And I say that because I have patients that seek me out specifically because I explain things different than other providers. Same condition, same diagnosis, but appreciate the explanation. And it's not a dumbing down, it's truly an explanation of the situation, and they appreciate that. And so it's really important that we understand, yes, we are full of all of this book knowledge and all of these management skills, but if you cannot talk to a patient and you cannot interact with the patient, it's gonna go south. And you're gonna have terrible outcomes. So thank you, I appreciate that.
I do want to say one other thing, which is in some ways, my book is about it's about the medical system. It's not about, right? And I know I talk a lot about doctors and nurses and the people that are also working in the hospitals, including security people and food service people. And I've come to learn that that's kind of low-hanging fruit, because the real problem has to do with the system itself, the number of minutes and the amount of time that you're not expected to spend with somebody. I saw a study recently that said, on average, a pregnant person spends, I think it's like 2 hours over the course of their pregnancy with their provider. So the time for interacting gets diminished, gets denigrated in the interest of capital, right? In the interest of money.
Correct. And that interaction in that time is vital because it makes a difference, which is, also an explanation as to why we have those outcomes in postpartum, because they haven't been explained that something may arise or what to look out for or who to seek out if something happens. And so it's important we also carry over into postpartum. And we do have a few questions here that I want to share with you. Dr. Wilson Mitchell states, Dr. Davis, your work is tremendous and so validating. I'm wondering if you are in any way interested in searching some of the history of the Black midwives who did flee from the US, some through the Underground Railroad to live and work in Canada. This is the research she's doing at this time, and to uncover the hidden history of Black midwives in Canada. It is rich, but so many missing pieces of the puzzle.
So, and this is from who? I'm not looking at the question. From
Dr. Wilson Mitchell. She is a practicing midwife in Canada.
Yeah, I mean, I'm aware of some of that history. That's not my area of expertise, but it sounds like you're doing it. And I would love to know what you know, right? I have worked a little bit with midwives in Canada, the Netherlands, Great Britain, Brazil. But I think that's an amazing, that is an amazing project, to take a look at that mobility, the movement, and what were the differences. How is it that midwifery care is embraced, or even doula care is embraced differently in a place like Canada? We reify Canada. We act like racism doesn't exist in Canada. So
it exists everywhere. Everywhere. Another question that I had, you made mention of Ashley Bay and Yvette Santana as experiences within the hospital personnel and their experiences with the medical racism. And as I read through their experiences, I couldn't help think, as a Black woman, a Black midwife, Black mother myself, I often get this thought of, damned if you do, damned if you don't. We are often stereotyped as not being educated enough and therefore know no better, but then we're too educated or too wealthy and think, we just know it all or know too much. How can we as the birthing community just do the obvious and learn to listen and address the patient's concerns head on with facts and a well-explained management plan?
So, this isn't something that I'm an expert in, but I am working through this with Karen Scott, who's
yes.
A lot of that has to do with quality implementation, right? quality, assessing the quality improvement and quality implementation. We have to see what works. And we know that there are better outcomes when people listen. I mean, it's just, we look at, the thing is that there's a challenge because even, I forgot what Medicaid, CMS, Medicaid, I just drew a blank on what CMS stands for. The government knows that midwifery models of care work better. There's more time, more caring, more listening, more engagement, more follow-up, more interaction. They know it. I just finished reading a report that they know it and they say, oh, we can't do it. Why? Because managed care controls the way we can or cannot implement other models of care. Now, I'm not an expert on quality improvement, quality implementation, or Medicaid reimbursement, but I do know, or I do think that the birthing community might want to take a step back. I also think, and this is something that I've just recently learned, residents are a group of people who have a lot of power and can actually, without fear of losing their jobs, that they can actually engage in advocacy around certain kinds of care practices because they're in a training position. I think we need to think about recruiting more residents on the side of engaging and implementing midwifery models of care, and making demands at the state level. This is the degree to which you want the state involved anyway.
Right.
But the other way that the birthing community can do something different is, I really believe that we need more options. The US is a sort of one-trick pony, right? Like, why don't, I used to say, I think I said this once, I felt like there should be a birthing center at the same sort of spatial increment as post offices. Just, and why not? Why not have birthing centers?
Yeah.
It's about, but that all of it, a lot of it is about, it's about competition. A lot of it is about competition. And I'm aware of the fact that in the medical field, people have generally two different perspectives about birthing. Some people view it as a risk and other people view it as natural, right?
Yeah.
It's also the same thing for people that are actually pregnant. They might view it in those ways too. This isn't just the medical field. So, but at any rate, I think the answer to the question is, I think we need something other than management plans. I think we need a broader set of options.
Yes, thank you for that.
I don't mean to interrupt, but I just wanted to make sure I'm enjoying this and there's a bunch more questions, but I also want to make sure, Carrie, that you take a few minutes to tell folks about the work going on in Chicago. I mean, you're doing so much important work in this domain, and if you could just take a few minutes to talk about it. We've been sharing a bunch of links to examples of your work, but just talk about it in the context of what Dr. Davis has been talking about.
Sure, thank you. I am charged myself to do my due diligence and try to change the narrative as well. And I appreciate you, Donna, you talking about the residents and how we can recruit them to do something different. And they do have a power that they probably don't understand that they have, but I also have a power as well. And I'm using that to really provide a model of care that I think will address some of the things that are happening here in Chicago, specifically our maternal mortality rate and the things that pop up, in postpartum in our Black moms and Black birthing communities. So specifically, I just received a grant almost a year ago, working in collaboration with UIC to explore 4 evidence-based components that will really show the importance of patient engagement and addressing structural racism, but also highlighting the use of Black midwives for Black women in the community utilizing nurse care coordination and making sure patients have wraparound services, such as, if they're having high blood pressure issues, they have contact with cardiologists or endocrinologists for, diabetes, or if they're needing, housing questions answered, or transportation issues, resources, or needing a doula to really just help them in the home with some things after having their baby. We tend to traditionally focus on patients having their babies, seeing us at 6 weeks, and we're just kind of done with it. And we cannot be. I mean, that's a vital time for a birthing person and their child. And we have been not successful in kind of these one-stop shop situations, models of care, or one entity to try to address those situations, and it has not worked. And so I had this thought, and my team has helped me brought it to fruition, of having group prenatal care run by a Black midwife for Black patients, who will also have a Black nurse who will also facilitate those nurse coordination issues, whether it be socially, emotionally, physically, medically, however we need to address it, but also making sure they're not only supported in labor, but also supported in that postpartum period. Having that collaboration, that access, that reach to that nurse, to that doula, who will come into their home and help them for the entire year. However they see fit, they need that help. And we have them more engaged in their care, feeling, hopefully having more trust in the system, that we are investing in them, therefore they are trusting of us. And so we're getting ready to recruit here later in the year, with hopes that it will be well received, with the hope that we can upscale it to, other entities have the support of the state and federal individuals, so that this is looked at as a vital model of care that can address the situations that we are seeing among our Black birthing patients.
It's amazing. That's amazing. I want to say something about when you said group prenatal care, you notice something. Partly because I've just started a new project.
Okay.
Because, why not? The truth is that prenatal care was eugenic. And we know that group prenatal care works really well for Black birthing people.
It does. It does.
And so, to answer the question about why do we still have similar statistics or same rates of difference from 1850 to now, I think has something to do with the fact that it has a eugenic origin.
Right. And we need
that's what I'm writing about. And I'll begin.
Yeah, we have to change what we've been doing, because it has not been working, and it's evidence-based.
It wasn't meant to.
Yeah, it was not. So yes, that's the work that we have going on. In addition to the other links that they shared, I created Melanated Midwives to diversify the profession. We just do not have enough Black midwives. We used to be that we used to do this. And so to have this big shift to a profession that, barely sees 6% of its profession at African American, and even less in other minority groups, is just very disheartening. And so I really, I'm intentional about making sure that our student midwives are supported financially, and making sure they have mentorship, and are working with them to get into this work, and really, have a stake in caring for individuals that look like them.
Great.
I'm starting to ask questions. I realize there's a couple of questions in the chat about that are sort of under the guise about training, people interested in knowing how do you become a midwife, people asking questions about specific kinds of continuing education classes that you might recommend. And I just want to put one question, because I have the microphone. I want to put a question in the mix that I was thinking about while you were talking, Donna, and I was also thinking about Carrie, is there was this years ago, Toni Morrison was writing about racism and whiteness in textbooks in schools. And most of my research is more in K-12 education, but she talked about when you look at old history textbooks, of course, the narrative is completely racist and in all these ways. And she said, there's lots of ways of thinking about how to change that. One is to, do what people used to do probably around the era when I went to school, which is they would add those little sidebars about like a Black scientist, or there'd be a little thing about George Washington. They wouldn't change the rest of the text. They would just add a little sidebar. And then there was a push to rewrite the textbooks, but she put on the table, like, we should study the old textbooks. We should study the narrative that got told, the patterns of erasure, the kind of stories in the way that you were talking about. And I thought about that story, Donna, when you showed that CDC poster, which I don't think you were offering up as an historical relic, but it seemed like
I wasn't.
Yes, it was a kind of, but because this idea that Black race is a risk, right? There's a cause itself of preterm birth, to me is so, and I'm just going to put this out there, and you can pick this up or talk about whichever aspect about the training you want. But it seems to me, in my contact with or work with folks for thinking about medical education, like that notion, the kind of, and you've talked about this and that came up in your stories, and I think, Carrie, you were sort of referencing us about how much kind of, you were calling them racialist assumptions and narratives, racist assumptions and narratives are so pervasive in ways that are not only deeply troubling, but like in moments when we're most vulnerable, are like on the, are just part of the space. Anyway, I'm curious about like what your ideas are about when we think about training, and how do we get people to really engage with this in kind of deep and complicated ways?
Well, one thing that I would say, I recently gave a talk to a group of, I guess, residents and doctors at Weill Cornell, and I showed them a picture of a pregnant body that had been done by Cheyenne Varner. Do you know who Cheyenne is, Carrie? Yeah, so Cheyenne Varner is a doula and a graphic designer, and she has this thing called the Educated Birth thing. It's a company. And there are pictures of differently shaped bodies, different color bodies, showing the fetus in different colors, which she did before the Nigerian doctor did it. He's getting all the props.
The props, yes, she's done it.
Doing it, but I can't, like the number of people who said, I have never seen a brown body. So just in the educational process, shifting what the textbooks look like and what gets included is a part of the process, right? I'm working with a maternal fetal medicine doctor now, and we're doing a small project together, but I asked him, I wanted to see his textbooks. So one of them is it's a OTTER, I think, Otter, some publisher. And it's like, I don't know, 600 pages. And in that textbook, outside of 2 or 3 illustrations, all bodies are white looking. There are 3 that are not. And those 3 are all linked to either STIs or an adverse birth outcome. So you begin to see the insidious ways in an educational process where Blackness, brownness, other than whiteness is not normative. And people learn that, they learn it. And so I think one way has to do with reclaiming textbooks. But I think the other way is, I think everybody needs to read Deirdre Cooper Owens, and people need to read Raina Hogarth, Medicalizing Blackness, looking at how Black body, that history. I think we do a disservice by not having all medically trained people, whatever it is, midwifery, nursing, LPN, CNAs, doctors, OBGYNs, all the specialties. We do a disservice if they do not have to take humanities or social sciences, and it should be required, and not just like one class.
Agreed.
There are, I think I'm going to try one. Well, we're about to run out of time. I think there's so many interesting questions, and we will capture them. I hope you're looking at them. But I wanted to give you both a chance just for like one or two final thoughts that you wanted to leave with the folks here. There are a lot of questions about racially concordant care and what you think about that, and in particular about other aspects of the medical system. But I'll let you pick up whichever you want. And Carrie, you want to start with one set of thoughts that you want to leave us with, and then we'll go to.
Sure. There's reference about racial concordant care, and we're, the premise of our research is that, and my work with melanated midwives, but, having more providers that of color just speaks to the need for change and how we can influence that change, partly because of, like Dr. Davis said, the interactions and the assumptions and the exaggeration or the minimization brought to the table, the diagnostic lapse, all of that was just like things that can be changed not only in how we change our interactions as an individual, whether you're Black or white or brown, but also knowing that if people of color are requesting a provider of color, we should be able to provide that. There is some way that we can rest their spirits, their concerns, honor their experiences, get them through their birthing journey. If that's what they're requesting, we should give that. If those individuals can help them through that, we need to do that. And that's just been my experience since being a midwife and in healthcare is, with the highlight of all of the numbers and the deaths, Black women are not being heard, and they feel more comfortable with someone that looks like them that they can identify with. And so if that's what we need to do to start changing the numbers, then that's what we need to do.
So I agree with you, but I also have a note of caution, which is, Black medical professionals are trained in the same system that white medical professionals are. And so in some instances with the people that I talked to, it didn't matter whether the doctor or the nurse was Black or white or Latinx or what have you. But in a lot of instances it did. And the thing that I want to say though is when we think about the impact of racism on Black birthing people, we must also remember that their families are impacted and that those health professionals that care about what they are doing are also impacted. The burden of being looked at as the doctor or the nurse that is going to make sure you live is a heavy, heavy burden. And I don't think that there's enough research that takes a look at the impact of racism as it pertains to medical professionals having to mediate racism on behalf of their client, their patients. So.
Donna, that's the next talk. Another hour and a half.
Yeah, absolutely. Okay. I was just thinking, Carrie, Don, we were hoping to have you here in person. Next year, we'll bring you back, the two of you back together. Let's get a room full of folks on the West Campus together to really think about this in a kind of bigger way. I loved hearing the two of you talk. Yeah.
I know we don't have any time, but I was reading Professor Rutherford's question about biospecimens and biomarkers and epigenetics. And I agree that we definitely need to think about responsible biological research. But one of the things and because there is in our stressors that racist stressors that impact people's outcomes. But one of the things that I really want to pay attention to is not the stressors that are external to the medical profession. Like I keep wanting to say, we need to look at the treatment that medical professionals perpetrate on Black and brown bodies as a stressor, not just, oh, I live in a bad neighborhood, or oh, I live in a good, or I have a job that's got a glass ceiling, which is what Leith Mullings was looking at. Absolutely I don't want to take attention away from the medical system itself. So, but I'd like to talk more about that. Okay.
Yeah. Well, let's plan a part 2. Absolutely. Thank you both so much. This was really wonderful. It's just such a powerful conversation and such a timely one. I had a whole set of questions for you, Donna, also about this particular moment in history right now and fights around reproductive justice. There's so much work to do, but we are so grateful for Carrie for all of the work that you are doing here in Chicago. So important. We want to lift it up at all times, and Donna for all the writing and important thinking you're doing and the work you're doing. And we will bring you here and we will get everybody together. Thanks everybody for coming. Thanks very much to the provost again for being here to welcome us. And we hope to see everybody again soon. Thank you so much.
Thank you.
Have a wonderful day. Yeah.
Thank you, Donna. So good to see you.
So good to see you too next
Okay.
year.
Yes. Bye-bye.
Bye.